Hello, everyone. Thank you for joining today's web interface support call for ACOs, groups, and virtual groups. This presentation will be followed by a Q&A session where attendees will have an opportunity to ask questions via phone in the support call questions box, and CMS Subject Matter Experts will address as many questions as time allows. Also, to note, a recording in the slide deck from today's call will be posted on the QPP webinar library within the next 2 weeks. Now I will turn it over to Sandra Adams Slaughter at CMS to begin.
Thank you. Welcome everyone, and thank you for joining us today as groups, virtual groups, and ACOs prepare for quality reporting. I'm Sandra Slaughter from CMS. Joining me on the call today are other CMS experts and contractors who will share helpful information on the CMS Web Interface quality reporting and answer your questions following today's presentation. Today's call will only focus on 2022 CMS Web Interface quality reporting. You can contact the Quality Payment Program Service Center with any of your questions regarding cost, promoting interoperability, improvement activities, MIPS, or other quality reporting in general. Today's slide deck, recording, and transcript will be available on the Quality Payment Program webinar library within the next 2 weeks. Next slide, please. This is a disclaimer slide about this presentation. Information in the presentation is current at the time it is published, but I urge you to please be sure that you're using the source documents and links that are provided throughout the presentation. And please stay tuned for any communication from the Quality Payment Program or Shared Savings Program regarding any updated information. Next slide, please. And next slide, please. The CMS Web Interface will close at 8 p.m. Eastern Time on March 31st, 2023. Your submission will be automatically accepted at submission close. As a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website. 2022 is the final performance period for MIPS groups, virtual groups, and APM entities to report using the CMS Web Interface. Transition resources are available on the QPP Resource Library and the QPP Webinar Library. The CMS Web Interface will remain an available collection type only for Medicare Shared Savings Program ACOs reporting via the APM performance pathway for the 2023 and 2024 performance periods. Next slide, please. The last support call for the CMS Web Interface 2022 submission period will be held on Wednesday, March 22nd, 2023 from 1 p.m. to 2:30 p.m. ET. Topics will include the CMS Web Interface reports, frequently asked measure questions for the following measures: PREV5, breast cancer screening, and MH1, depression remission at 12 months. Additional topics may be added prior to the support call. Next slide, please. Materials from the February 8th and February 22nd support calls are now available on the QPP Webinar Library. Next slide, please. The CMS Web Interface API, or Application Program Interface, is available all year for testing in the developer preview environment. Please review the links listed below for more information. Next slide, please. As a reminder, requesting an other CMS approved reason is a way to skip a patient attributed to a measure during the denominator confirmation. These requests are reserved for circumstances that are unique, unusual, and not covered by any of the denominator exclusions or denominator exceptions identified in the measure specifications. Requests must be submitted through the CMS Web Interface and make sure to provide detailed information about why the patient should be skipped. It isn't necessary to request another CMS approved reason if there's an applicable denominator exclusion, there's an applicable denominator exception, or the patient is not qualified for sample. And also note the following requests will be denied. For fall screening for fall risk, requests to skip a non-ambulatory patient will be denied. The denominator exclusion for non-ambulatory patients was removed. The expectation is that all patients are screened for fall risk, excuse me. Next slide, please. Submitting your request for an other CMS approved reason during the last days of the submission period could cause your request not to be processed. Requests submitted after Wednesday, March 23rd, 2023 may cause your request not to be processed prior to the close of submission. So we encourage you to submit your request as soon as possible. You can learn more about how to submit an other CMS approved reason request by reviewing the 2022 CMS Web Interface User Guide starting on page 52. Now I'll hand the presentation over to Katie Moore, who will review frequently asked measure questions.
Thank you, Sandra. Next slide, please. The first measure we're going to cover today is PREV6 for colorectal cancer screening. The intent of this measure is to screen patients who are 50 to 75 years of age for colorectal cancer. In regard to the use of telehealth for PREV6, documentation of a colorectal cancer screening may be completed during a telehealth encounter. Next slide. Next, we'll move on to our frequently asked questions for PREV6. Question 1, does a Cologuard test count for numerator compliance? The answer is yes. A FIT DNA test during the measurement period or the 2 years prior to the measurement period is acceptable for the measure. Does a FIT, not FIT DNA, count for numerator compliance? Yes. FIT during the measurement period is acceptable based on the 2022 PREV6 coding document within the numerator codes for the FOBT code variable. Question 3, if the FOBT is done in the office and sent to a lab, is it acceptable for this measure? If not, where must it be done to be valid? The response is no. Per clarification with the measure steward, the intent is to exclude all FOBTs performed in an office setting. FOBTs performed at home and brought into the office to be sent to a lab meet the intent and performance for the measure. Next slide. Question 4, can we report FOBT results that are interpreted by our in-house labs? We understand that FOBTs obtained in the office or via DRE aren't acceptable. The response is, as long as the FOBT itself wasn't performed in the office or performed on a sample collected via DRE, the test results are applicable for the purpose of reporting the 2022 PREV6 measure. The measure specifications aren't prescriptive on the type or location of the lab that can interpret an FOBT test. Question 6. The initial population of the 2022 PREV6 measure specification indicates that a visit is required during the measurement period. We know that data can be documented during a telehealth visit. Is an in-office visit required if a telehealth visit is done during the measurement period. The response is that the quality action isn't tied to a particular encounter the clinician may have with a patient, including telehealth. If there's medical record documentation to support a colorectal cancer screening was completed within the appropriate timeframe specified for the type of screening performed, and the results are documented, it would meet the requirement for the 2022 PREV6 measure. Next slide, please. Question 6, are blood-based colorectal cancer screenings with some examples given here, EpiPro-Colon, Colovantage, Guardian, etc., acceptable for the PREV6 measure? The response is no. The numerator doesn't include blood-based colorectal cancer screenings. The measure specifications define the appropriate screenings as follows: FOBT during the measurement period, flexible sigmoidoscopy during the measurement period or the 4 years prior to the measurement period, colonoscopy during the measurement period or the 9 years prior to the measurement period, FIT DNA during the measurement period or 2 years prior to the measurement period, and CT colonography during the measurement period or 4 years prior to the measurement period. Next slide, please. Okay, and the second measure we're going to be covering today is PREV7, Preventive Care and Screening Influenza Immunization. The intent of this measure is for patients aged 6 months and older seen for a visit between October 1st and March 31st to receive an influenza immunization or report previous receipt of an influenza immunization. As it relates to the use of telehealth, you may report previous receipt of an influenza immunization during the flu season during a telehealth encounter. The influenza immunization itself cannot be completed during a telehealth encounter. Next slide. Okay, on to our frequently asked questions. Question 1 is, if data is pre-populated into the CMS Web Interface for the 2022 PREV7 measure, does our organization need to validate that information is correct? And the response for this one is, if the CMS Web Interface has been pre-filled with yes, based on claims data, no further action is required. If the influenza immunization information is not pre-populated, you should refer to the patient's medical record to determine if the immunization was administered in accordance with the measure specifications. Question 2 is, what are the documentation timing requirements for the numerator of the 2022 PREV7 measure? The response is that the medical records should support that the refusal, exception, or previous receipt occurred during the appropriate time frame. This would be August 2021 through March 2022 for the 2022 reporting period. Documentation for the PREV7 measure should be during the measurement period and specific to the flu season being reported. If medical record documentation supports the quality action or exception submitted as relevant to the flu season being measured, it's acceptable. Next slide, please. Question 3, the numerator guidance states that influenza immunizations during the flu season or the patient's previous receipt of the influenza immunization may or may not be completed during a telehealth encounter. What does may or may not mean? This is just to clarify that the influenza immunization itself can't be completed during a telehealth encounter, but a screening where the patient may report previous receipt of the influenza immunization between August 1st, 2021 and March 31st, 2022 can be completed during a telehealth encounter and meets the intent of the measure. 4 is a documented history of an egg allergy sufficient documentation to use the denominator exception for a medical reason. The response is no. A documented history of an egg allergy in the patient's medical record alone doesn't meet the intent of the denominator exception for the 2022 performance period. Documentation of an egg allergy must be during the measurement period and support that the allergy is still active during the appropriate time frame, which again is August 2021 to March 2022 for the flu season being reported to qualify as a denominator exception. Next slide, please. Okay, I will hand things back over to Sandra to go over resources and where to go for help. Thank you.
Thank you, Katie. These next few slides will outline the available CMS resources. Please note that 2022 submission resources are available on the Quality Payment Program Resource Library. We encourage you to review these documents if you have questions on quality requirements and measures. We'll continue to communicate any future postings on upcoming support calls. Next slide, please. Materials from previous CMS Web Interface support calls can be found on the Quality Payment Program webinar library. Next slide, please. For those transitioning to another collection type for the 2023 performance period and beyond, resources are available on the QPP Resource Library and the QPP Webinar Library. Next slide, please. Finally, this slide contains links to resources available for Shared Savings Program ACOs. We encourage you to review the materials available here for more information. If you, next slide, please. If you need additional assistance, please refer to the contact information listed on this slide. And now I will hand things over to Olivia to begin the Q&A.
Great, thank you, Sandra. And yes, so now we will begin the Q&A portion of today's webinar. And just a quick reminder, you can ask questions two different ways. So the first can be through the Q&A box. And we have seen folks starting to type some questions that way. And you can also ask a question live through the webinar audio. And the way you would do that is just click the raise hand function that you should see at the bottom of your screen. So we'll start with a couple of questions that we have received so far. The first question is on PREV 12, and it reads, for the PREV 12 measure, can a patient with an active diagnosis of schizophrenia or schizoaffective disorder be counted as a denominator exception?
Hi, this is Katie. So in order to use the medical reason, there aren't specific diagnoses tied to the denominator exceptions. You would just need to ensure that your medical record documentation supported that the patient was not screened for depression due to their diagnosis or cognitive ability or something along those lines, just to support that they weren't screened due to their particular diagnosis, they were unable to answer the questions and so forth. Thank you.
Thank you, Katie. And we have a couple of other questions for you. The next one says, does the suicide screening meet the requirement for the depression screening measure?
So this measure is, this is in reference to PREV 12, it's specific to the depression screening. So that depression screening, in order to meet the numerator, a suicide risk assessment would not be appropriate. If a patient screens positive for depression, a clinician could opt to complete a suicide risk assessment when appropriate based on the individual patient. However, for purposes of the measure, a suicide risk assessment or additional screening using a standardized tool would not count as a follow-up plan. So if it's clinically appropriate for the patient, you would go ahead and do that, but you would still need to document a follow-up plan as defined by the measure in order to meet the numerator.
Thank you. And then just one other question, Katie, on PREV 12. Can a patient with an active diagnosis of dementia be counted as a denominator exception?
So this would be the same response in that you would just need to ensure that your documentation supports that the patient wasn't screened due to their diagnosis or condition, just to ensure that there is a clear reason why the patient wasn't screened for depression for purposes of the measure. Thank you.
Great. And Jamie, a question for you on Prev 7 that came through. It reads, what if beneficiary receives influenza immunization 7 to 10 days before August 2021 or 7 to 10 days after March 31st? And
Hi,
the,
thanks for some.
sorry, go ahead.
Sorry. Sorry about that. Thanks for submitting this question. We did have an internal dialogue really quick about this, and we believe the best option would be to submit for a CMS approved reason request, or just take a look at it. We may ask for a little more detail, but please go ahead and submit this for consideration. Thanks.
Great. And the next question reads, for DM2, can an A1C result from an inpatient hospital setting be used to satisfy the measure if it is the most recent result in the patient's medical record?
Hi, this is Angie. Let me take a look here. Yes, the measure doesn't limit the numerator to a specific setting. So an inpatient HbA1c can be used. Thank you.
Thanks, Angie. And I think there's one other question for you. Does repeat in 5 years or 10 years meet intent of result for Prev 6?
For the Prev 6 measure, there needs to be documentation in the medical record that has both of the following, and this is in the measure specifications. It says there has to be a note indicating the date the colorectal cancer screening was performed and the result or findings. Documentation of normal or abnormal is acceptable. So that's what you would have to have a medical record in order to meet the numerator. The follow-up on perhaps a colonoscopy is not what's being measured. Thank you.
Great. And then we did just receive request for clarification for a question on the Prev 12 measure. So just reading it again, can a patient with an active diagnosis of schizophrenia or schizoaffective disorder be counted as a denominator exception?
Hi, this is Katie, and I apologize that I pasted in the wrong question. So this was, I think, the question that we wanted to address for this particular Prev 12 was, can a patient, or excuse me, if the patient had a depression screening earlier on with a review, which would be that interpretation of negative or positive for depression, and then subsequently had another depression screening where that interpretation did not occur, which should be used in order to satisfy the intent of the measure. And the response to this is that the measure does use the most recent screening for depression, and in order to meet the intent of the measure, there does need to be that documentation of negative or positive. So if the most recent depression screening doesn't have that interpretation of negative or positive, and there's no potential follow-up documented if need be, then it would be considered a performance not met for purposes of the numerator. Thank you.
Thank you, Katie. Okay, going back to a couple of other questions that we have seen come into the Q&A box. This one is on Prev 10, tobacco, and it reads, we have observed that the look-back period for performance year 2022 is different from the look-back period from 2021. So they are just looking for clarification of why the measure has not been suppressed for 2022.
Hi, and this is Jamie. Thanks for this question. Really appreciate it. In order to suppress the measure has to be like deviated from its clinical guidelines, or it has to have an analytical issue. So by definition, this measure would not meet suppression. However, I do see that there's a question down in the queue, 1224, in regards sort of emphasizing and sort of pulling this question out just a little bit further. So to handle that question too, and I'm sorry I'm jumping ahead, but maybe this would be best submitted as a help desk ticket, just because I want to make sure we have time to vet that question. And honestly, not going to be able to have an answer today, but do appreciate that person being able to communicate that question. Just acknowledging that I don't have enough resources. We're going to have to think about that question before we provide our response. So again, thanks for the questions, and please submit that minute 24 based on your time zone. Please submit that through the help desk. Thanks.
Great. In a couple of questions, on HTN, are we required to include blood pressure taken at an urgent care visit for acute respiratory illness with wheezing? This was the last visit during the measurement period. Can we use blood pressure from the visit prior to the acute illness visit?
Hi, good afternoon. This is Carol from the PIMS team. And for this particular situation, urgent care encounters are actually included within this specification. So you would use this particular, if it is your most recent, you'd use this particular value for reporting. Thanks.
Thanks, Carol. And one follow-up question for you. For HTN2, if a patient has a diagnosis of essential hypertension with an ICD-10 code of I-10 in 2021 and in April of 2022, the patient had a diagnosis of hypertension, but no ICD-10 code or description of essential hypertension. Would this patient still be included in the denominator for HTN2 or be marked no diagnosis found?
So if you cannot, this is Carol again, if you cannot confirm that the patient has continued essential hypertension into the first 6 months of the 2022 year, then if you can't find that, you would need to use a combination of like written documentation as well as your code in order to make sure you can confirm numerator compliance. Coding alone would not be sufficient. So yes, looking through your medical record, if you can find that they do still have essential hypertension, then they could be included. If not, then no. Thank you.
Thank you, Carol. Joyce, a quick question for you. In the first ACO year, does a 100% ACO quality score translate to a 100% MIPS quality score for practices participating in a Medicare Shared Savings Program ACO that also needs to report MIPS?
Hi, so there's been a transition starting in PY 2021 to the APM Performance Pathway, or APP, for quality performance reporting. So there's no longer a pay for reporting option, but first-year ACOs can meet the quality standard by completely reporting quality measures, and ACOs that are not considered to be first-year ACOs will be scored according to the APP criteria, under which an ACO's quality performance score must be equivalent to or higher than the 30th percentile across all MIPS quality performance category scores in order to meet the quality performance standard. And in order to get clarification on the impact to MIPS score for eligible clinicians, we'd recommend submitting a ticket to the QPP Service Center. Thanks.
Thank you, Joyce. Katie, a question that came through for you for Prev 12 depression screening. It says, does a telehealth encounter require a video or is a phone call sufficient?
Hi, thank you. I do want to note that this response is for all measures within the CMS Web Interface, not just specific to Prev 12. So in terms to telehealth for the CMS Web Interface for numerator compliance, a telehealth encounter may include medical information that's obtained over the phone, email, or other electronic communication used to interact with a patient. So if the quality action of the measure is captured during a telehealth encounter, the medical record documentation is required to support what's reported through the web interface. So again, for numerator compliance, it is a little bit more lenient in terms of telehealth usage in that a telehealth encounter can include phone, email, or other electronic communication. Thank you.
Thank you, Katie. And one additional question on Prev 12 that says, would a documented result of negative or positive be needed to meet the measure?
So the measure specifications do state that a clinician's interpretation of negative or positive is required. How specifically that is documented is up to your organization, but you would need to ensure that your documentation does support that interpretation of negative or positive. Thank you.
Great. And Jamie, one question for you on Prev 10. In the description of rates, it states received tobacco cessation intervention on the date of the encounter or within the previous 12 months. And so the question is just asking, does this mean 12 months exactly from the day?
That would be true. And there's an example within this particular question that is analytically right. It meets with the measure's intent. So I'll just read it. The patient received screening and was identified as a tobacco user on 9/20/22 and received cessation intervention on 9/15 of 2021. And since that's within that 12 months, that would qualify and meet the performance of the measure. So thanks for this question.
Great. So I think we can shift now. It looks like we have a couple of folks with their hand raised. Jason, we are unmuting your line. And so you may just need to unmute on your end as well, and then you can ask your question.
Hi, can you hear me?
Yes, we can hear you.
Thanks. So I wanted some clarification on the Prev 12 questions regarding exceptions for things like dementia and schizophrenia. Just to clarify, I want to make sure. So you're saying we cannot count them as exceptions, even if they have an active diagnosis of, let's say, schizophrenia in their medical record, unless the clinician specifically says, I did not give a PHQ-9 because the patient has schizophrenia. Am I interpreting that correctly?
Yes, your documentation does need to support the reason why they weren't screened. Since there's not specific diagnoses tied to this exception, you would have to support why that quality action wasn't completed for the patient.
And in the event of an audit, having a diagnosis itself is not enough to prove that that's why?
I mean, in terms of for all measures, I mean, the expectation is that your medical record documentation supports the information you report. So if you're reporting, if you didn't complete a quality action for the patient, you would also need to have supporting documentation showing why that wasn't completed.
Right, but that's it seems a little ridiculous to me that you have to have something that specifically addresses that screening. I mean, the medical record and documentation is that the patient is actively schizophrenic.
I understand that. There's also, a need to tie a reason to why the numerator wouldn't have been completed for that reason. I don't know that we can speak specifically to audit, but for purposes of meeting the intent of the measure, it would be required that your documentation supports why the screening wasn't completed. In this instance too, it's an option to submit another CMS approved reason, just outlining, this patient wasn't screened, what that particular reason was. You might need some additional information, but that could be one consideration for this scenario.
Okay, thanks.
Yes, and I was going to say, Jason, we can share your contact information so you and Katie and the team can connect if you have any other questions. Okay, we'll turn back to the Q&A box for a couple of other questions that have come in. One is on Prev 7. does a patient have to refuse a vaccine each year to be excused from the denominator, or can we use a refusal from the previous year's document in the chart?
Hi, this is Jamie. Thanks for this question, Lisa. Yep, every year the intent of the measure is that we screen those patients and make sure that we're documenting within the medical record. In this instance, that the patient refused. So thanks for the question. Let us know if you need any clarification.
Great, and one other question regarding, it says regarding the following statement of the HTN controlling high blood pressure measure spec, can you please clarify how it affects infusion visits specifically for chemo and non-chemo patients? And the statement is taken on the same day as a diagnostic test or diagnostic or therapeutic procedure that requires a change in diet or change in medication on one day before the day of the test or procedure, with the exception of fasting blood tests.
Yes, this would apply if the diagnostic test and or therapeutic procedure, meaning the chemotherapy or the infusion visit, I shouldn't assume it's chemo, required a change in the diet and or a change in medication on or one day before. So it would be appropriate to move to the next most recent value if this applies.
Great, and the next question is on Prev 12. If there's a score of 0 on a PHQ-2 and the tool guidance indicates score 0 is a negative finding, will this count?
Hi, so again, I do want to address that, the expectation when submitting data through the CMS Web Interface is that your medical record documentation supports the information reported. So we cannot tell you specifically how to document. You would need to have that supporting documentation in your medical record to show negative or positive. Thank you.
Thank you, Katie. We did get a question on Prev 13. If they fall into the first population, should we leave the next two population boxes blank and go right to if they're taking a statin? If the other populations have any other resource, it gets flagged as irregularities when uploading.
Hi, this is Katie. So I can answer from a measure perspective, and then if there is an issue in terms of upload or something that the product team would maybe need to address, then I might have you submit a ticket to qpp@cms.hhs.gov to address any technical issues. However, the intent is that if the patient falls into the first population, then you would move on to the numerator portion. So I don't believe you're supposed to need to go through the other two populations, as it's kind of a waterfall. If they don't apply to one, you would move on to the next and so forth. But if they fall into population one, then the numerator action would be based on that information. Thank you.
Great, and the next question is on Prev 10. If a patient is screened for tobacco use and notes that they're ready to quit, but they don't receive cessation or education, will they be considered numerator compliant?
Hi, this is Jamie. Thanks for this question. I can't really speak to what you might be seeing in the medical record just because I don't have access to it, or I'm also unable to see it, but I can speak to intent. And so for this particular measure, the intent is that the patient receives, once screened positive for tobacco, receives that brief counseling, 3 minutes or less, and or pharmacotherapy. So if you are not able to determine whether or not this particular action occurred based on what you're seeing in the medical record, then the patient may be or probably would be performance not met, unfortunately. So I would just make every effort to really look at that chart, see what you can find, or look for pharmacotherapy in that instance, perhaps. So thanks for the question.
Great. And another question that came through on the depression screening measure, and it asks, or it says it excludes patients with depression or bipolar disorder. Why would we need to restate that the patient has depression when the specs exclude the patient from the measure?
So I just want to add clarification around the denominator exclusion. So the exclusion is assessed prior to any encounter during the measurement period. A diagnosis of depression or bipolar during the measurement period would not be considered a denominator exclusion. Thank you.
Great. And just a reminder, if you do have a question, please go ahead and submit that through the Q&A box. And we'll give it just another minute or so in case you have a question that we can cover. It looks like we did just receive one additional question for you, Deb, for HTN. During a phone call, a patient reported blood pressures this past Tuesday and Wednesday. Can we calculate the VP dates based on the date of the telephone call?
So just to confirm, a patient-reported blood pressure is not acceptable for the hypertension 2 measure, so you would not want to be using a patient-reported blood pressure. Thank you.
Great. And one other question, if it is documented in a February 2nd, 2022 office visit note that the patient got the flu shot in 2021, can we count it? There is not a specific 2021 date, but it was recorded during the 2021 to 2022 flu season. And just to read the question one more time, Jamie, I'm not sure if you're able to answer this one.
Oh, I was on mute. I'm so sorry. I was on mute. I just wanted to I just wanted to address this question. I'm actually researching this question. I know it was submitted twice. I saw it get dropped in again, so I just wanted to address it. I'm probably going to put information to address our ServiceNow inquiry help desk, and hopefully we can just take a little more time with this question just to make sure we get you the right answer. I am looking at that definition of previous receipt, but I think I'm going to want to run this one through the team just to make sure that we answer consistently. And so if you could just give us a little more time, I'll go ahead and drop that information, and please submit this as an inquiry. Thanks so much. Sorry about that.
Thank you, Jamie. Katie, one question for you, just asking for clarification on the denominator exclusions for PREV 13.
Sure. So the denominator exclusions can be found on page 6 of the 2022 PREV 13 measure specification, but just to review those quickly, the exclusions are patients who have a diagnosis of pregnancy at any time during the measurement period, patients who are breastfeeding at any time during the measurement period, and lastly, patients who have a diagnosis of, sorry, I'm going to probably say this incorrectly, and I'm so sorry. rhabdomyolysis at any time during the measurement period. And I, again, would just point you to page 6 of the measure specifications for Prep 13 to review those and the appropriate timing associated. Thank you.
Great. One other question, it says, according to the specs, a patient-reported blood pressure is acceptable, and they ask if you can just please clarify and address this.
Hi, yes, this is Carol. So for this measure, telehealth is actually included within the measure. You need to use the most recent blood pressure information that is obtained, and it can be obtained over the phone, via email. Telehealth encounters for the web interface are limited to just Medicare billable encounters. However, speaking of telehealth, we'll go through this again in reference to the numerator element. Only blood pressure readings performed by a clinician or a remote monitoring device are acceptable for compliance with this measure. And that includes blood pressures taken in person by a clinician or blood pressures measured remotely by an electronic device capable of transmitting the blood pressure data to the clinician. Blood pressure readings taken by a remote monitoring device and conveyed by the patient to the clinician are acceptable. And it is up to the clinicians, it's their responsibility to, and at their discretion to confirm that that device used to obtain the blood pressure is considered acceptable and reliable. However, blood pressure taken by the patient using a non-digital device or a manual blood pressure cuff with a stethoscope should not be included. So just make sure your medical documentation supports what you are reporting. Telehealth is included. That's it. Thanks.
Great, and we will go back to the phone line. Anne Marie, we will unmute your line and you can go ahead and ask a question. And it looks like you, oh, there you go.
Yeah, I had 2 questions. I wanted to go back to the depression screening question that Katie answered. And just to be sure, so if a patient has depression or bipolar anytime prior to the measurement year or that visit, then they would be excluded. You don't have to document that they're not doing the depression screen due to depression or bipolar, because that is an exclusion, correct?
So apologies. The earlier question, I believe, was related to diagnosis of dementia.
No, that was the prior question, and then somebody else asked a question. It's in the Q&A about whether or not, why would they need to document that they have depression or bipolar again?
Sure. Yep. Sorry, I just wanted to clarify that piece of it. So in terms of the patients with depression or bipolar, the denominator exclusion for that particular one is assessed prior to any encounter during the measurement period. So a diagnosis of depression or bipolar during the measurement period would not be considered a denominator exclusion, and the expectation is that those patients would be reported upon if they have an applicable depression screening during the measurement period.
Right. So let's say the first visit was February 15th and depression is listed under the active problem list with the appropriate codes, then they have not had, they would be having an encounter, but the problem list was active with that diagnosis. So they would be excluded. It's a carryover from the year before. It's still, patients aren't seen. If their last visit was sometime in October or November of the prior year and depression is on their problem list, then it's still on their problem list when they come in for their next visit, unless somebody took it off their problem list. So I'm just asking, that would still be considered a diagnosis that's active.
Sure.
You need to do the PHQ.
Right. So, yeah, I mean, in this instance, it sounds like the depression or bipolar was prior to an encounter during the measurement period. So that would be considered an exclusion. If it was diagnosed during the measurement period, that would not be considered a denominator exclusion.
Okay, and then I also wanted to just bring up the fact that, for 2 years now, we keep getting the same answer to our questions regarding, is a score of negative acceptable? Is this acceptable? Is that acceptable? And we get the same answer that, you can't speak to what we have in our EMR, that our documentation needs to support the intent of the measure. But is there a way that we could get some ideas of what is acceptable and what is not acceptable? Many ACOs are creating behavioral health programs right now to address this problem with depression. So as we create those programs, we would want to be creating them such that we're also meeting measures, the depression screening measure or the depression remission measure, but we're not getting the appropriate feedback. So how do we know how to document exactly if we don't have examples? So just by saying your documentation should meet the intent, I think that most people on the call would agree that it's frustrating and we're not being led in a direction that's helpful.
Hi, this is Sandra Slaughter, and we don't want to dictate what you, the way you document, but we do want for you to be able to share documentation that meets the measure specifications. So, so that's why we respond in the way that if the intent of the measure is met, that will be acceptable documentation. The measure specifications are available for you to be able to create your documentation the way you want to document your measure from that. But I think it's pretty specific in the documentation about the tool that you have to use, and that the provider has to interpret the result. So we don't want to again dictate what you put in your medical record.
I guess specifically examples of things that have failed in an audit. So if the main question that we all ask is a score of 0. Our providers want to say that is negative, and that why do they have to address and add a documentation that it's negative when even the tool itself says a score of 0 is negative. So unless they overwrite that and say it's positive, and then, if you have a system in place like that says everybody in our ACO agrees that a score of 0 is considered negative and otherwise would document as positive, we don't even know if that would hold up in an audit unless you've been audited. So I'm just saying, like, at some point, some examples of good documentation and examples of poor documentation or documentation that would most likely fail would be helpful.
Point taken. Thank you. And I do again suggest looking at the specification and the list of suggested validated tools and that information.
Okay. I think we'll move on to a couple of others. Lisa Brown-Rogers, we have unmuted your line and you can go ahead and ask your question.
Hi, good afternoon, everyone. I actually I have a question regarding our EMR system. We transitioned to Epic in January of 2023. However, for the 2022 measurement period, we used NextGen. And I saw that someone responded and said, send a ticket in, and we sent a ticket in and we haven't heard anything back. So I was trying to see if anyone on this call had an answer to that question.
This is Kara with ACOPOS. I can address that. I think the issue that needs to be clarified through the ticket process is to ensure that any medical record documentation that is used to support the measure is documentation that was available at the time of care. And so you would need to confirm that the records that are in Epic, which came after the measurement period, that is documentation that was available during the measurement period under the prior EMR. So if it was not documented until 2023, it would not be available to use for 2022 reporting.
Okay, so I know that you guys have a system, well, it's a system in process for any member assigned to our practice to request medical records from a different facility. But since we have converted over to a new EMR system, we do have access to those records. Are we able to use documentation done by another provider and not by our practice? Because some of the members on our roster may only be assigned because they're members of our specialty clinic and not primary care clinic.
Yes, it is acceptable and in fact encouraged to coordinate between providers within and outside the ACO to obtain the medical record documentation, as long as it meets the specifications and was available at the time of care. You can obtain that from other providers. And if you do want to seek further clarification about your situation, we can work through the help desk ticket.
Thank you.
Okay, moving on, Tara Armstrong, we have unmuted your line, so you'll just need to unmute on your end and you can ask your question.
I'm sorry, I didn't mean to raise my hand. Sorry.
No problem. All right, we will turn back to the Q&A box for a couple of other questions that have come in. The first question is on HTN, and it says, if a patient turns 86 during the measurement year and has multiple visits during the measurement period, do we need to report the most recent blood pressure reading when they were 85 or the most recent reading during the measurement period, even if it was when they turned 86?
Hey, this is Carol. I may not be the person to answer this question. But from the measured perspective, if the patient is outside of the age range, I wouldn't think they'd be included, but I guess I'll have to defer this to RTI.
This is Kara. Yes, that is correct. If the patient turns 86 during the measurement period, they are not qualified for the sample and they could be excluded. If you wanted to submit a ticket to confirm the birth date, we could explore that, but we would not expect someone to be qualified for the sample if they are turning 86.
Thank you so much, Carol.
Great. And a question that we received on Prep 12, are you looking for mild or moderate or major depression score from the PHQ-9 tool to be considered as positive?
Hi, so this is Katie, and the measure does not provide guidance as what would be considered negative or positive. And I do want to note that it's not specific to the PHQ-9. There's other depression screening tools that could be utilized to meet the intent of this measure. So it doesn't provide guidance as to, what categorizes a patient as positive or negative for depression. That would be determined based on the results of the depression screening and, negative or positive as the guidance is outlined within the specific tool. And then also on the clinician's interaction with that patient. Thank you.
Thank you, Katie. And Angie, a question that we just received for you on performance year 2022, Prep 13. We have a patient who has an ASCVD diagnosis and is taking a statin, is also listed in the EMR that he has an allergy to statin. Should this be an exception due to the medical reason, or should he be marked as taking a statin?
Hi, a denominator exception is remove the patient from the performance denominator only if the numerator criteria isn't met. So if the eligible patient, if the quality action has been performed and they're on a statin, then they should be reported as met. Thanks.
Okay, we will give it another minute or so. If you do have any final questions, please go ahead and submit those through the Q&A box, and we will give folks a little bit more time to submit a question. We do have one person with their hand raised, Andrea Taylor. We have unmuted your line. So you'll just need to unmute on your end and you can ask your question.
Hey, I'd like to bounce back to what Angie just said about denominator exceptions. If she could repeat her response on that last question that she addressed regarding if the measure was met or not met in using the exception, that would be great. I was thinking in previous years, we had discussed the fact that if they are an exception for any reason, that they should not be included in the measure regardless of if they actually met the measure, if that makes sense.
It does. I think that you are maybe getting it confused with a denominator exclusion versus an exception. So, because that would be true for exclusion.
Perfect. Okay, that may have been, sorry, that's where my wires were probably crossed. Okay, great.
Yeah, you would always look for the exclusion and not include a patient, in the measured population that isn't meant to be there. But if they are included in the denominator, and then the quality action isn't done, if there's a documented denominator exception, then you could report that.
Perfect. Thanks for the clarification.
You're welcome.
Great, and it doesn't look like we have any additional questions at this time, so I think we can go ahead and conclude the Q&A portion of today's webinar. And Sandra, we will turn it back to you.
Thank you, Olivia. Thank you all for joining us today. As a reminder, the slide deck, recording, and transcript from today's call will be available on the Quality Payment Program Resource Library in the next 2 weeks. Our last support call is scheduled for Wednesday, March 22nd, 2023, from 1 to 2:30 p.m. Eastern Time, during which we'll cover the CMS Web Interface reports and frequently asked measure questions regarding PREV 5 and MH1. We hope you'll join us. Thank you.